All right, welcome everyone. Welcome. We're going to go ahead and open the session. I'm Michelle Decker from Johns Hopkins, and I'm so thrilled to welcome you to this session, really focused on violence against key populations. Really want to thank our conference organizers for making this session happen. There is such a theme of inclusion and equity, anti-discrimination at this event and in the world currently. And we really know that our key populations are most affected by HIV, and in so many places in the world are so very affected by violence, gender-based violence, other forms of violence and discrimination. I'm really thrilled, and I want to congratulate our panel on the great work. You're going to be hearing from all kinds of different types of key pops, as well as some really nice geographic diversity in the session. So I'm really thrilled to introduce our guests to you, our speakers to you today. A couple things before we get started. I want to let you know that the poster presentations that you're going to be hearing about today are located down near the forum. They're not immediately outside. I really encourage you, you're going to hear sort of a 5-minute elevator pitch about each of these presentations. I really encourage you to visit the poster sessions and follow up with our speakers for more information about that. The posters will be up for all 3 days of the conference. You'll have plenty of opportunity to get those details that you're very interested in, and really encourage you to have those conversations as well. To make the most of our time, we're going to just go one by one. Please, we'll save up the questions for after our speakers, 5 minutes each, so we should have plenty of time for discussion, and we really welcome your input and questions and comments after this, the presentations go. And with that, I would like to invite Tolu to come kick us off with our presentation with her work in Nigeria. Thank you.
Okay, good afternoon, everyone. My name is Tolu Jaibo, and I work with Heartland Alliance International, Nigeria. And this abstract is looking at self-reported violence, perpetrators, and post-violence care that was received by key populations in the Integrated MAPS HIV Prevention Project in Cross River State in Nigeria. Okay, so Cross River State is one of the 36 states in Nigeria. It has a HIV prevalence of 3.4% and key populations prevalence. So for female sex workers, 11.3. For men who have sex with men, 13.5. And for people who inject drugs, 5.8. And that's according to a survey in 2014. So the time frame that was looked at was October 2016 to October 2017. And during that time, over 20,000 key population members were provided with HIV comprehensive services. So looking at violence, violence was defined as power or force that results in actual or threatened harm against a key population member. And the types of violence were categorized into 3: physical violence, emotional violence, and sexual violence. And they include, but they're not limited to, assault, forced detention, and torture for physical violence. Stalking, blackmail, stigma, and discrimination were categorized as emotional violence, and rape and sexual assault and other forms of sexual assault were categorized as sexual violence. As you can see on the screen, so we had actually 629 key population members report violence. So that comes up to be about 3% of those that were reached with HIV services, but they reported 834 cases of violence. That's because in one particular incident, there could be more than one type of violence. So a particular key population member could be exposed to both physical and emotional violence in one incident. As you can see as well, there were much higher rates of physical and emotional violence recorded than sexual violence. All right, so we move to the perpetrators. So perpetrators were classified into state and non-state actors. And examples of state actors include law enforcement agencies and healthcare workers, while non-state actors included clients, partners, families, community members, and strangers as examples. The data showed that overall, there were more non-state actors than state actors that were perpetrating violence against key population members in the state. And that was consistent for female sex workers and men who have sex with men. However, when it came to people who inject drugs, it changed completely. So we had 62% of perpetrators being state actors, so people who inject drugs, and just about 34% being non-state actors. So the trend completely reversed when it came to people who inject drugs. For post-violence care services that were provided, we provided three broad categories of post-violence care: medical, legal, and mental health care. So under medical care, this included provision of post-exposure prophylaxis, STI and HIV testing and screening and testing, and then also treatment for injuries and referrals to healthcare facilities for injuries that we could not treat in the facility. For legal care, that included alternative dispute resolution, included facilitated release from custody, and also included litigation if that was necessary and if that was wanted by the victim. For mental health care services, we provided psychosocial support and counseling for those that were victims of violence. So in conclusion, our data show that an average of 11 key population members a week report violence in Cross River State. And our recommendations really from this were that there needs to be increased screening and documentation of human rights violations, and that care for victims of violence should include especially legal education, safety and security counseling, and there needs to be a strong engagement of security stakeholders, especially when we're looking at the data of people who inject drugs. There's a need to engage security stakeholders on how to deal with key population members and their rights, that everyone is a human being at the end of the day. So these are essential to promoting an enabling environment for key populations to access HIV services. And that's it. Thank you very much. So next on, I will call on Elwin, who would make his presentation on partner violence.
Thank you. And thank you for coming to this session. So today I'm going to talk about partner violence, particularly among men who have sex with men, black men who have sex with men, or MSM, or black MSM. I'm pretty sure I don't need to tell anyone in this room about sort of the disproportionality of men who have sex with men, or MSM, at least in the United States, and their overrepresentation in the HIV/AIDS epidemic. What I do want to point out is that, in particular, the disproportionality experienced by black MSM. In fact, the latest sort of projections are 1 in 2 African-American or black MSM in the United States are likely to seroconvert or become infected with HIV in the United States. And I like to use this figure to point out really one thing, and as striking as these stats are, it also points out another particular message. And so if you think about what HIV is, it's a bunch of ribonucleic acids and some proteins, folded in certain ways. The virus itself cannot tell the race of the people involved. And so it can't be a biological process that explains sort of the differences you see here as a function of the different MSM groups. Actually, the virus can't tell sexual orientation either. But if we think about what's going on here with the MSM, if it's not fundamentally a biological or biomedical process, what would actually explain the disproportionate rates we see, or the disproportionate likelihood of becoming infected with HIV? If it's not biological, that leaves really only social or socio-political kind of factors that are driving the disproportionality. And so that's what's led to sort of this notion of, well, what are the social conditions around the epidemiology of HIV that explains disproportionality? And this notion of a syndemic, which is sort of intersecting, multiply occurring epidemics. It was originally developed by Merrill Singer and company to look at what was called a SAVA syndemic: substance abuse, violence, and AIDS or HIV among women. And so it's the co-occurrence and the interplay between these epidemics that leads to increased rates of HIV, increased rates of substance abuse and violence. Or in some cases, if you believe in intersectionality, sometimes the whole isn't necessarily worse than the sum of the parts. Sometimes there can be a buffering effect, such as if you become inured to racism and stigma and oppression, that might confer some protective advantages in some of the other areas when it comes to sort of dealing with violence. For example, So that's the notion of syndemic, is sort of co-occurring and interacting epidemics. And this has also been applied for MSM, particularly with mental health, substance use, HIV, and more recently what they've added to the mix is also partner violence. And so there have been some studies looking at partner violence among MSM as part of the syndemic or adding it to the syndemic for MSM. But I do want to bring out this one thing in particular, again, focusing on the Black or African-American MSM. And all these prior studies have not really focused on Black MSM in particular, with one small exception, a tiny study, or a study with a small sample size, that focused on Black MSM and violence among the syndemic. So what we want to do is to fill that gap and expand upon that and use a larger sample size. And so that's what the poster that I have is about. It really is looking at, well, what is the prevalence among a large sample of Black MSM and prevalence of partner violence in particular, and then look at, is there an increased likelihood of engaging in HIV risk or substance use among a larger sample of Black MSM. There are a lot of details here, but essentially what I want to point out is that we've recruited folks using both traditional outreach and social media from New York City, and ultimately we ended up with a sample of just over 1,000 Black MSM. Some of the measures really, I'll draw your attention to thinking about partner violence. And in particular, we use the Revised Conflict Tactics Scale, the CTS-2, which is widely used historically to look at partner violence. And then we added a couple items. One is what we call gay-related partner violence, which is threatening or actually outing one's partner as gay, and HIV-related violence, threatening or actually outing one's partner as HIV positive, regardless of that partner's actual status. Basically, we were testing the hypotheses of if the presence of partner violence, is that associated with a greater likelihood of HIV risk indicators and substance use and misuse. And ultimately what we found is that, yes, the prevalence of perpetration and experiencing of partner violence among Black MSM is high. Lifetime, around a third of our sample experienced or perpetrated partner violence, both separately, and they didn't completely overlap. If we looked at just within the past 30 days, which is current, over 1/5 of our sample experienced partner violence in the past 30 days. And we found strong support for partner violence being associated with greater indicators of HIV risk, in particular, not knowing one's HIV status, as well as engaging in sexual risk, condomless anal sex, number of male sexual partners, and binge drinking and substance use. So all told, is we found support for partner violence as being part of the syndemic among Black MSM. And in the poster I'll go through is how we teased out particular aspects, forms of partner violence, and in particular the impact of gay-related partner violence, specifically as really being a concern with respect to illicit substance use as well as sexual risk behavior. So with that, I need to thank some of the contributors to this work, and I need to also turn you over into the good hands of Kalande. So thank you.
Okay, good afternoon, everyone. My name is Kalonde Malama, and I'm a doctoral student at Aix-Marseille University in France, and I'll be talking to you today about the prevalence and predictors of client-initiated violence among Zambian female sex workers. I have no conflict of interest to declare. Zambia is a country with a generalized HIV epidemic, and female sex workers in relation to the general population have a much higher prevalence of HIV, with recent estimates placing that as high as 56%. Another epidemic that exists in Zambia is that of gender-based violence, with 43% of women aged between 15 to 45 reporting ever experiencing gender-based violence. So in this context, female sex workers are prone to violence from their male clients. And couple that with the illegality of sex work, and you have a situation where female sex workers are less likely to report any acts of violence to the police, who paradoxically represent the major entry point into violence response services in Zambia. So then, by what mechanism does violence expose female sex workers to HIV? Well, the literature tells us that when faced or threatened with violence, a female sex worker has less agency to negotiate condom use. And during a forced sexual act, a client of a female sex worker is less likely to use a condom. So in this backdrop, we developed a cross-sectional study with the objective of determining the prevalence of HIV amongst a cohort of female sex workers enrolled in an HIV incident study at the Zambia Emory HIV Research Project, and also to find out the determinants of this violence, and specifically looking at the sexual environment, sexual history, and risk behaviors as potential predictors. So we asked 419 female sex workers if they had ever been physically struck by any of their clients since they began practicing sex work. And 39% of them responded yes. The predictors of violence in our analysis were having sex at the client's home, which, in line with literature, is due to the interplaying environmental aspects of control, concealment, and isolation. So in his own home, a client is more likely to feel in control and at liberty to be violent in the knowledge that any such act would be concealed from the public, whereas the female sex worker is likely to feel isolated from any potential source of help in the event of such violence. We also found that the consumption of alcohol was a predictor of violence in our cohort, which again is consistent with the literature that states that the consumption of alcohol renders female sex workers vulnerable to gender-based violence. And finally, we found that female sex workers who were physically forced during their sexual debut or first ever sexual experience, which in our cohort took place at the mean age of 15, were also more likely to have experienced violence from their male clients. This is also supported by the literature that states that violence in childhood creates in its victims a tolerance to further abuse in adulthood. So, to conclude, we found that sexual environment, sexual history, and alcohol consumption are important predictors for violence against female sex workers. We recommend that risk reduction counseling for female sex workers highlight the dangers of sex in the client's home and of alcohol consumption. We further recommend that life course interventions be implemented to protect adolescent girls from physical and sexual abuse during childhood, and also that these interventions involve young men and boys in order to redress the existing gender norms that allow violence to prevail. And finally, and more broadly, we'd also like to recommend that HIV prevention interventions include gender-based violence prevention counseling and referral to violence response services. Thank you very much. And with that, I'd like to introduce the next speaker, Michelle.
Good afternoon. My name is Michelle Lanham with FHI 360 and the Linkages Project. Linkages is USAID and PEPFAR's flagship project addressing HIV prevention, care, and treatment for key populations. And I'm pleased to share the results of this study with transgender women in Latin America and the Caribbean. And I'd like to start by thanking the trans women who participated in the study and courageously shared their experiences with us, as well as the peer data collectors and the civil society organizations that supported the study. This study was conducted by the United Nations Development Program and Linkages in partnership with the University of the West Indies and local organizations that serve trans women in Barbados, Trinidad and Tobago, Haiti, and El Salvador. We conducted this study because Linkages wanted evidence to inform how we integrated gender-based violence prevention and response within our HIV services for key populations. In addition, UNDP wanted more information about GBV against trans women in the region to support the development of anti-discrimination laws and policies for that population. We used a participatory approach, engaging with trans women throughout the research process, including that trans women were trained as data collectors and actually did the interviews with their peers. They conducted 74 interviews across the 4 countries. And those interviews covered trans women's experiences of gender-based violence in education, in the healthcare sector, in police encounters, and in other state institutions. So what did we find? 80% of participants in the study reported that they experienced some form of violence in healthcare, education, and in police encounters. The most common form of violence that they experienced was emotional abuse, which included scolding, gossiping, and derogatory comments about trans women's behavior or appearance. But other forms of violence were also very common, including physical, sexual, and economic abuse, and other human rights violations. In schools, participants not only experienced very pervasive emotional abuse, but also physical violence and threats of violence, and some were also received failing grades, were suspended or expelled because of their gender expression or perceived sexual orientation. In healthcare, it was really common for participants to go in for services, and in their encounters with healthcare staff, they were blamed. They had their health issues blamed on their sexual orientation or gender identity. They also found that trans women were very often made to wait, given lower priority than other clients, and in some cases were even denied services. So, for example, one trans woman in El Salvador talked about an encounter with a nurse where she said, "Look, I'm going to save you for last because of how you are." Trans women also talked about receiving substandard care in these healthcare services, noting that healthcare providers were generally uncomfortable with giving them services and or considered them less worthy of high-quality care than other patients. In encounters with the police, when trans women went into a police station to make reports about crimes that had been committed against them, they were treated rudely and were often blamed for those crimes that had been committed against them. Trans women who were involved in sex work talked about being blackmailed by police, so police demanded sex or money in exchange for not arresting these women for being involved in sex work. And in El Salvador and in Haiti, there were some cases of arrest or detention because of one's gender identity. And then we also heard that it was really common for women to experience stigma and discrimination when they went in to get official documentation, like an ID document or a passport. Some were forced to actually alter their physical appearance before they could get that identity card, and some were refused those identification documents altogether. So the consequences of this violence that they experienced were that trans women were unable to obtain the services that they needed, and some ended up just avoiding services altogether. They also talked about feeling ashamed and humiliated and less than. Some women did actually have positive experiences with service providers, and they talked about those in detail, how these providers would be respectful and supportive and go out of their way to meet their specific needs. But those experiences were certainly the exception. In summary, service providers in these settings not only failed to meet the needs of trans women, but further discriminated against them, and this furthered trans women's social, economic, and health vulnerability. Being unable to access education, healthcare, legal justice, and official documentation is a violation of trans women's human rights, and it denies them full citizenship and the ability to live safe and productive lives. We're using these results in a number of ways to improve policies and programs in the region. UNDP is using the results to advocate for anti-discrimination and gender identity laws that include allowing trans women to self-determine the name and gender that appear on their official documents like ID cards, medical records, and school records. Linkages is training healthcare providers to deliver non-discriminatory gender-affirming services and also to help providers detect gender-based violence among their clients and provide first-line response and then provide further referrals. They're also training police on the need on trans women's human rights and the need for stigma-free police services. And Linkages has many peer educators who can be linked with victims of gender-based violence, and they then accompany them to services to make those services more accessible. In conclusion, we strongly urge governments and the public health community, each and every one of us in this room, and even more so those who are not in this room, to help address gender-based violence against trans women. This is an essential step in not only meeting our HIV targets, but also in helping realize trans women's health and human rights. I forgot the animation, sorry about that. We also just had this Accepted in Violence and Gender, so please stay tuned for that. And this is our team. And now I'd like to invite up Maria. She's going to talk about human rights violations against women who use drugs.
Hi everyone, my name is Maria. I'm from Eurasian Harm Reduction Association. We are the regional organization that works with the community of people who use drugs in 29 countries from Eastern Europe and Central Asia. And today I will tell you about our study of women who use drugs in Estonia. First, I would like to tell you how we came up with this idea. We heard from our community in Estonia that in some parts of Estonia, children were taken away from their mothers based only on the fact that they use drugs. So together with Canadian HIV Legal Network, we developed a methodology and then found a partner in Estonia. It's Lunest, it's an organization of people who use drugs, and went to Tallinn and Ida-Virumaa. It's now I'll be confused, northeast of Estonia, and collected 38 in-depth interviews with women who use drugs. It was like the first attempt to systematically collect and analyze such data. And based on these interviews, we submitted a report to the UN Committee on Economic, Cultural and Social Rights, and then presented it with one of the women we interviewed. And now Estonian government received questions that they will have to answer about the availability of services for women who use drugs and the attitude from social workers toward them. This is briefly what which violations we discovered. The disclosure of HIV and drug dependence status. A lot of women said that opioid substitution therapy services, they disclose the information about the drug dependence to their employees, to their families, or about the HIV in the hospitals. They have like special room for women, pregnant women, to deliver a baby if she has HIV. And 25 cases out of 38, basically all women that had children, they had problems with child protective services, and they were limited or deprived of their parental rights. The next one is normalization of domestic violence, that even if the woman calls the police, police usually listen to her partner. Like he says, she is a woman, she's using drugs, and she has a child, so she's like showing her what's right. And actually, after that, she might have problems with child protection services, so women don't call the police in these cases. And there are also no shelters that accept women who use drugs, and also there are no rehabilitation centers that accept women who use drugs with children. So if the woman wants to go to the rehabilitation center, if she has no relatives or if she's estranged relationship, she has to give her child to the orphanage just for a year because it takes a long time. And police abuse and strict drug testing is... there was one case when a woman, she has a child and she has prior convictions, and so she's in police database, and they just stop her in the streets. They know that she's going to take her child from the school, but she forced her to pass the urine drug tests, and she had to do it because if she refused, she will have to go to the police precinct, and then this procedure could take hours, then she will be late for school, so she agrees, and this is like normal practice there. And actually, if the person refused to pass the urine drug tests, they will use a catheter. Yes, it's... And anyway, she will give it, but it will take time, so people just do it on the streets. And Estonia has OST program, NSP program, and other programs, but these human rights violations, they deter people from these services because they're afraid to get in this system. So you can learn more about it in my poster. There are some quotes from the women. And actually, we have a campaign from our region, Chase the Virus, Not People. So also come to our stand. Thank you. Bye. And the next one will be Brooke.
Okay, so as some of the previous presentations touched on, this presentation is really about structural violence and how the environments that people live in are contributing to their untimely death. It's well established that people who inject drugs are at increased risk of mortality. However, more research is really needed on the causes and predictors of death in contexts like Mexico and in border communities like Tijuana. There are an estimated 10,000 people who inject drugs living in Tijuana, and this is a city with substantial markets for both drugs and sex work, and is also one of the busiest border crossings in the world. HIV prevalence among people who inject drugs is 4%, and even higher among subpopulations. For instance, women who also trade sex is around 12%. However, HIV is really only one factor that might underlie risk for mortality in this community. Tijuana is characterized by public injecting, high levels of homelessness, and also limited access to affordable and quality drug treatment. In Mexico, recent changes in legislation have also impacted the lives of people who inject drugs. New drug policies, which passed in 2009, both decriminalized the possession of small quantities of illegal substances and mandated the expansion of an addiction treatment program with the expectation that police would be diverting injectors to treatment rather than to jails. So the El Cuete project is a prospective community-based cohort study of people who inject drugs in Tijuana, Mexico, and it includes individuals age 18 or older who reported injecting drugs in the past 30 days. Study participants were recruited through self-referral, word of mouth, and street outreach.
And in this analysis, we're looking at PWID who were recruited between April 2011 and December 2017. And it examines all-cause mortality rates, which were determined by death certificate for confirmed deaths or through ongoing follow-up with participants and their contacts, which we are calling unconfirmed deaths. So a total of 863 individuals were followed for up to 78 months. There were 133 deaths, 57 confirmed and 76 unconfirmed, which resulted in an incident density of mortality of 18 deaths per 1,000 person years for confirmed deaths and 39 deaths per 1,000 person years for all deaths, including confirmed and unconfirmed deaths. Mortality rates were substantially higher among people who were HIV positive. Importantly, confirmed deaths resulted primarily from homicide and trauma, overdose, but also things like septic shock, HIV-related causes, and substance use-related causes like HCV or organ failure. Baseline HIV seropositivity was associated with a 4 times higher risk of mortality, and being arrested for drug sales was associated with a 6 times higher risk of mortality. Stopping injection for even a short period of time, for 6 months or more, was protective. So the mortality rate for PWID was high, and it did stem from HIV, but also from other factors associated with the structural context. Particularly concerning was that over half of all deaths stem from preventable causes like homicide or overdose, which suggests that there's really a need for more public health efforts to reduce marginalization, create safer environments such as supervised consumption facilities, and to ensure that PWID have access to medication-assisted drug treatment. Similar to other studies, HIV infection was also a major factor contributing to high rates of mortality in this population. In Mexico, healthcare is universal, including ART. However, access can be limited, especially for stigmatized populations like injectors. Previous studies have shown that in Tijuana, PWID relative to non-PWID were the least likely to have been previously tested or to have initiated HIV care, which really suggests a need to improve the HIV care continuum for injectors in this community. Of note, interactions with police were a highly significant predictor of mortality. Despite drug law reforms designed to shift to a public health model, police encounters for injectors are really common. These include arrests, detainments, harassment, and violence. Our results show that these interactions, which could serve as an opportunity to connect PWID to supportive services, may instead be a source and a facilitator of health harms. Training and other structural interventions focused on the integration of law enforcement and public health continue to be needed to reduce mortality among injectors in this context. At the same time, I want to note that these results point to the need to also develop alternative income generation strategies for drug-involved communities so that they don't need to rely on drug sales for economic survival. Finally, we found that even short periods of injection cessation were associated with a lower risk of mortality, which indicates a need for improved access to MAT to reduce injecting. At the time of this analysis, however, there were only 3 private methadone clinics in Tijuana, and they all charged a fee, which can be prohibitive for populations like injectors who might not be able to afford to access those services. Overall, the high rates of mortality in this community really serve as a call to action for public health officials to prioritize the lives of this population by preventing their deaths. Thank you to our funders, and there are no conflicts of interest, and thank you to our study staff and participants.
Great, thank you. Thank you. Really exciting. I want to thank our whole panel for this incredible work that is being done documenting violence and human rights violations in populations that we know are already so vulnerable. This really requires incredible sensitivity, adherence to ethical protections for these groups. And so let's give a round of applause really for our whole panel. Thank you so much. And we did, thank you, just a wonderful job staying on time. And so really these sessions are really designed for discussion and dialogue. So I'm going to invite people to come forward to the microphones with questions, ask people to introduce themselves and where they're from, and address members of the panel. Probably take a couple of questions, and then we'll invite a couple of our panelists. We'll take them in a batch sort of fashion. And while folks are coming forward with questions, I'll just let people know, those of you that have arrived, more recently arrived, the posters themselves for this session are downstairs, they're upstairs. They're near the forum entrance. So if you need more details, that you want to follow up with any of our presenters or refer your colleagues, encourage you to do that. That's where the posters are going to be located. Okay, so thanks.
Thanks very much. It's a very interesting panel. My name is Hakan Seçkin. I'm from London School of Economics. Just two clarifications, one from Michelle. I'm just curious to hear what was specific to these violence patterns you talked about in Latin America, because, I mean, otherwise those patterns are pretty similar everywhere in relation to transgender women. So I was curious in terms of the specificity of the Latin America and the Caribbean region. And then one to Kalonde. In your conclusions, one of your points was life course interventions in terms of protecting adolescent girls from rape. I didn't quite understand how they link with sex workers. I mean, are you suggesting a lot of sex workers adolescent girls, or there's some other linkages? Thank you.
Hi, everyone, and thank you for the presentations. My name is Julia Lukumnik from the Open Society Foundations in New York. I'm curious to know, I mean, you've highlighted with great specificity a lot of the problems, and then you've given kind of broad-based policy solutions to address the structural issues. Certainly, we have to work towards those, and also those are very long battles to be fought in many of the locations where you're working. So I'm wondering if you were also able to highlight some kind of perhaps local, perhaps not, solutions that are being put into place right now to reduce the vulnerability or provide harm reduction services to some of these populations. Thanks.
All right. Hi, everyone. I'm Funke Olabosinde from Nigeria, working with Atlantic Alliance International. I'm directing my question to Maria. I was really touched when you're making your presentation about the abuse for the female, people who inject drugs in your country. I just wanted a little clarification. Is there anything you're doing to prevent all this abuse, the emotional and physical abuse? Because similar cases are happening in my country, Nigeria, and what we're doing is to engage the security agencies, the local security agencies, the gatekeepers of this population, to build their capacity, to train them, to let them know the implication of what they're doing, and also the implication of the action also to the country public health. And also, I want to know if you have what are you doing currently with the female period, pregnant female period? Do you have any reproductive health programs, activities for them to build their capacity in that, and also to link them up with necessary health facilities? Thank you.
So thank you for your very thoughtful questions. I think you make a good point that a lot of what we saw is consistent with violence that we see against trans women in other regions of the world. And really, a lot of it isn't necessarily new to those of us who work with those populations, but we have found that it's important to have systematic research done to really document in a different way what's going on, and that we've been able to use that as leverage with funders, with governments, with country programs to really invest in this area. So you're right, some of it's not necessarily new or different, and I wish that we didn't have to go through this long, lengthy process to prove to others that this is important. but we did. And it was actually really interesting because we did this across 4 countries that we saw actually a lot of more similarities across those 4 countries than we did differences. Some differences that we saw, for example, is that in El Salvador, there's just higher levels of violence in society generally, and we heard a lot more about the involvement of gangs, and there were more use of weapons in various forms of violence, for example, and that was the only place where we heard talk of like the military and soldiers also perpetrating violence in addition to police. And another example is in Haiti, that trans women, we really had to think about the language that we use there because the gender expression there is very different than in the other countries. So they're more perceived as MSM anyway, but that did happen in other countries as well. And then the question about well, I'll let other people respond. I can answer about how we're using these results specifically to address these problems, but I'm going to give somebody else a turn first.
Thanks a lot for your question. It's a very good question. So in my results, I pointed out that one of the predictors of violence was forced sexual debut. And I tried to specify that the mean age at sexual debut in our cohort was 15. So when I made the recommendation about life course interventions, I was referring to interventions such as, I'll give a concrete example, such as the Dreams Project. And so the Dreams Project works in schools, and they offer sex education to young girls, and that's meant to protect them from things such as violence that may occur. So essentially I was referring to intervening early to prevent disastrous consequences later on in the life course. I hope that answers your question.
I think I'll answer your question about the local solution. So part of the recommendations, most of the recommendations that I mentioned actually are a lot of things that we are doing on our project as well. So I didn't mention, but I'll just mention it now. So we have engaged community paralegals. So we've trained community members as paralegals to offer first aid, post-care prevention services. So most of the post-care prevention services are actually offered by community members before they're escalated to staff members if it's something that they can't handle. So that has been very effective for us. We also engage pro bono legal facilitators in the States that handle the litigation issues and then also facilitate release from police detention if that's an issue. Then we have done a lot of security stakeholder engagement, so speaking with the law enforcement agencies. Someone mentioned it as well on how to basically provide stigma-free police services and just how to be able to carry out their work in a way that is consistent with human rights. And just trying to also raise attention about the fact that when they are arbitrarily arrested and kept in detention for an unlimited period of time, then they are denied access to their drugs and denied access to healthcare. So trying to ensure that they understand that. We also have like little campaigns like Know Your Rights campaigns, and the way our project is also set up is that we work with local community organizations. So they also have different ways of also making sure to raise awareness about human rights violations, and then also how they have their own little methods. So we have an organization that has a black market campaign, which is just basically raising, if there's somebody that is a perpetrator of violence in the community, they have ways of telling other people in that community that they should watch out. So black market is just a local term for someone that is not, that is a perpetrator of violence, basically. So they have ways of circulating that information around to say that beware of this person is bad. So we have different ways that we're also trying to ensure that within our project as well, we can have tangible and practical solutions to the human rights violations that KPs face.
I'd like to quickly add, in the Tijuana context, What's interesting about the study is it shows that even in the context of drug reform, which we all want, there's still a lot of work to do, right? And so what is happening in Tijuana is there's some really interesting work being led by Steph Strathby, Leo Bolesky, and Jaime Arredondo, which is actually working with police to have interventions and sensitization towards working with injecting communities. And I think projects like that are actually interventions with law enforcement are so incredibly important to ensuring the health and safety of other populations.
I'm very sorry. Could you please repeat your questions, but using this microphone, because I really can't hardly hear you from that one. I'm sorry. Thank you.
I was just asking if you have any form of engagement with security agencies in your country to prevent all the actions of abuse, but especially physical abuse, of course, will lead to emotional abuse for the female who uses drugs, because you said you prevent them from accessing the healthcare services. And also, if you have any program for pregnant period, that's pregnant female who inject drugs, if you have reproductive health services for them in your country. Because in our country, we have like a one-stop shop. We don't refer them to the general facilities. We have facilities that are KP specific. So where it's like a free environment where they can access health services. So they don't get abused in the general facilities. So I'm just saying if you have such in your country and what we're doing presently to prevent all these forms of abuse.
Thank you. Unfortunately, no, there are no specific services for pregnant women who use drugs, so they get all this bad treatment from the hospitals and other medical staff. Actually, even in the OST programs or NSP programs, they also receive this treatment. We are trying to, this organization, Lunest, it's fairly new, it's like 2 years. Before that, there were no organization of people who use drugs in Estonia, and now they try to put their own people as peer consultants in every program that works with people who use drugs. So it's like only starting. Before that, we didn't have anything.
Sure. So thank you. For some of the more specific recommendations, I'm thinking about our population that we work with Black MSM, and what comes out with sort of these big structural changes that we can't make necessarily or quickly. When we work, say, with Black MSM, we talk about some of these things as actually manifestations, not of just sort of problems that you're encountering, but that these are actually forms of homophobia, heterocentrism, or racism. So the fact that Black MSM don't think about relationship counseling or relationship services, oh, that's for white upper middle class couples, right? We say, well, that might be true, it might be a cultural thing, or it actually might be a form of homophobia, either internalized or by the service providers not being trained to work with Black same-sex couples, for example. So we really try to inspire them, charge them, give them the tools to resist or to advocate, not just the lack or the lack of motivation for, say, relationship issues, but to really see that as a form of homophobia or heterocentrism. And the same could go for racism and the lack of services or the lack of friendliness of services. It's not how you're treated is just different. It's actually a form of racism or racism and homophobia. And so we try to highlight those.
Absolutely. Thank you. Thank you. We've got a couple more minutes, so I'll invite anyone else with questions to please come forward, and I'll actually take the co-chair's prerogative to ask a question of my own, and this is actually really for Brooke and also for Tolu, and others please weigh in, but I'm wondering, when we think about people who inject drugs in particular, both of you shared some really striking results on human rights violations, mortality for this population, knowing as well that we could have different identities within PWID, gender identities, other types of vulnerabilities. Did you do any stratified analysis? I'm especially thinking about gender, given some of the work work that we've been hearing about for women and girls. Just understand if the patterns may differ by gender identity or by gender within PWID.
Okay, there wasn't really space to disaggregate the data by gender, but the data, people who inject drugs data are disaggregated by sex. But the numbers did show that there are more male PWIDs reporting violence, but that also could be mostly because we do have more male PWIDs on our program, but we haven't, that's definitely something to consider as well, to do a more in-depth analysis to see if those trends do differ for male to female PWIDs, but at the moment that hasn't been done in depth.
In this analysis, we didn't find a statistically significant difference by sex. However, we do know that female injectors experience a range of factors that complicate their lives. They are more likely to engage in sex work, which involves elevated HIV risk as well as exposure to violence. In terms of interactions with police, they are often raped or sexually harassed. So there are differences in the realities of their lives. There's differences in the circumstances that might lead to their mortality or morbidity, but it did not show up in this analysis given the small numbers at this point.
I would just like to add that, for example, in our region, the problem is that we don't have disaggregated that data by sex. So we only assume the amount of people. And in Central Asia, it's so stigmatized for women to use drugs, so they don't usually come forward.
Wow, I'm so struck by the need to document, even in your last comment around gender disaggregated data by some of the other vulnerabilities, thinking about the syndemics issues as well. The needs are so tremendous, and I think what we've heard today, especially in this panel, is the need even sometimes simply for documentation to get that leverage, get that local specific data that allows us to say, this is an issue here, and these issues for key populations cannot be dismissed, right? And so for all of you here and in the audience that are working on documentation for human rights violations and understanding how those affect HIV infection, treatment, and care trajectories, we really can't overemphasize the need for this work. Any closing comments from any of our panelists? We've got a couple more minutes, and I also invite people to come forward and speak with our panelists in the remaining moments. Anybody have a final comment? Michelle?
I just want to say, if you are interested in how to more specifically address these issues, Linkages does have so many great guidance and training materials that we'd be happy to share with you. And that's not just for trans women, but also for MSM and female sex workers and people with injecting drug use. So both for preventing and responding to GBV and providing stigma and discrimination-free services and all of that. So please come see me afterward if you are interested in that.
I actually want to thank you for bringing up the research process and things like ethics and how we do this in a sensitive, competent manner. As you look at me and I'm talking about Black MSM, I can only imagine what you're thinking about, how I do that kind of research. And I don't mean to presume anything about the panelists, but I think hopefully maybe we can propose a panel on sort of how we do this research ethically if we don't necessarily match our target population.
I would just say that I love that this panel both touched on interpersonal violence and structural violence and the interplay between the two, because I think that's such an important part of how we think about violence more broadly, is we need to be looking across a level. A lot of these individuals of stigmatized or criminalized groups are experiencing violence on their daily lives from partners, from friends, from police, but also they're witnessing violence in their communities. And so the combination of those things can really lead to a lot of implications for health.
Absolutely. Well put. Well put. Thank you. Thank you, everyone.